This is the summary of antiarrhythmic drugs. There are about 15 drugs you should remember in 5 different classes. This is a modified Vaughan classification. Some of you like pictures and mnemonics, so I'm going to review this section with a lot of mnemonics. Okay, so this is how I remember antiarrhythmic drugs. That's why I remember when I am angry, I eat 1 spoon of salt, that is class 1, 2 betta fish, 2, then 3 bananas, class 3 potassium channel blockers, and 4 eggshells for calcium. And if I have torsades, torsade pointers, I will take IV magnesium. And if I have AV node dependent entrant tachycardia, Wolff-Parkinson-White syndrome, orthodromic re-entry, I will be specifically remember AV node dependent. I will be taking IV adenosine, very good. And another one, of course, all the above drugs are going to be the arrhythmic, like a fast heartbeat, but that is like a unique rhythms, right? Like a really abnormal rhythms we are going to take. But for the bradycardia, there is one drug I want you to remember, that is atropine. Because when you study the miscellaneous or other drugs, it is easy for you to remember atropine also. Remember, atropine is not the antiarrhythmic drugs, but if you are looking at ACLS guidelines developed by American Heart Association, you can see bradycardia drug is for the temporary solution is IV atropine, because it is only for symptomatic bradycardia. You give the IV and it will be okay. Then later for permanent solution, you can depend for pacemaker. Okay, let's stop atropine right there. We go through the other drugs, okay? So this is the story. This is a mnemonic I remember. Okay, so if you are asking me about IV drugs, these 3 drugs we were talking about, magnesium sulfate, I told you, that's a first line. That's before I memorize all the other drugs, this is the first thing. I can just keep it aside because it is a straightforward first line drug FDA indicated for, okay? All the hospitals use it and emergency ICU unit use it. Okay, let's look at it. IV magnesium sulfate. Any patients with hypomagnesemia or hypokalemia induced or any other drug induced torsade pointers, first line drug is IV magnesium sulfate. Give the IV, it will work up to 1 to 5 minutes. Slow IV, take up to 20 minutes to give one. Work really well. Very good. The second drug, adenosine. Always it is a rapid IV push. I'm going to explain what is the reason for that. That is very unique because it works really, really fast. And there is some special points you have to remember. This is actually literally resetting the heart. Specifically AV node. It's going to stop everything and replug or restarting your computer similarly, right? So if you're asking me what is the difference between defibrillation, like using electricity into the heart, if somebody has a heart failure, cardiac arrest, you can give defibrillator. Electricity is going to pass through all around the heart muscles, including SA node, AV node, Purkinje fiber everywhere, and cardiac muscles, and giving the electric current, right? But if you are asking about adenosine, IV adenosine, the target is AV node. There is a reason for that. Specific receptors are located in AV node. That is why adenosine is specifically, it's going to stop for a couple of seconds. Heart is stopped at the AV node and the conduction is blocked. Anything irregular arrhythmias, you just stop it and restart it. Okay, so let's review one by one, okay? So, okay, you got an idea about last 3 drugs, but just look at the generally the big 4 classes, okay? How I remember is, generally if any patient has any arrhythmias, even including atrial or ventricular, you can trust a drug which is Amiodarone. It is both IV available, oral drug available. Amiodarone is really a super drug with a very unique mechanism we're going to discuss. This is actually a true potassium channel blocker If you are asking me why it is better for both atrial and ventricle, you can trust if you don't have any other options or reason. In addition to potassium channel blocking, this drug can do little bitty sodium channel blocking, calcium channel blocking, and beta receptor, beta 1's blocking. So that's a really good thing. You can control that, right? Okay, fair enough. What if amiodarone? This is a super drug, but the problem is this has so much adverse effects, right? So, and also this is a long-acting drug. It will stay in the body for a couple of days, like a 50, 60 days in some patients. So in that case, you need different options. So I'm talking about in the emergency department, right? Like in ICU, support somebody with acute arrhythmia. Ventricle arrhythmia, okay, I can trust with amiodarone. What if I cannot use that patient who has like contraindication for amiodarone or cannot tolerate some other reason? I need another choice. So that is the one, lidocaine. Okay, let me tell you one more important point. If the patient already had a myocardial infarction, that means post-MI, the go-to drug, STEMI, go-to drug is lidocaine. That is a sodium channel blocker, class 1B specific drug. Okay, I will teach you all those later, but just review this one. So first point, good. So I'm going to just stick with the ventricular arrhythmia, that is life-threatening, right? Okay, I can depend on IV amiodarone. Of course, if you give it like really quickly, it can cause like really cardiac arrest. Therefore, you have to take about 10 minutes and like a slow IV, okay? But you don't have to worry about that details in this drug. We will go through that details later. Amiodarone first drug, okay, ventricular tachycardia. What if it didn't work? You depend on, especially if a patient has myocardial infarction, especially ischemic, right? Post-MI, ischemic tissue is so many here in the ventricle, and that is where this extra pulse is coming from. Arrhythmia is because of those tissues. You can trust on lidocaine. I am going to discuss the mechanism. Reason, lidocaine can easily work on the special tissues. Okay, we are done with the ventricle part. Two big drugs to remember. Let's focus on the atrial region. What if somebody has like a supraventricular arrhythmias, right? Think generally, so that's an easy step to study. So atrial arrhythmias, fibrillation, flutter, etc., right? The go-to drug is, and trustworthy for rhythm control drug is, beta 1 blockers. Beta blockers, of course, there are some non-specific drugs there like a propranolol still can be useful. But I want you to remember a specific drug, Esmolol. So that is actually for IV, for emergency department, ICU, work in 1 to 2 minutes. Very fast metabolized drug. After like 10 minutes, it's like 10-15 minutes, it will be like eliminating from the body, and that is a good drug, also trustworthy. Okay, specifically you can trust that. Why it is first line, I'm going to discuss in few seconds. What if a patient has beta blockers contraindication? We are sticking with the atrial, right? Mainly general concept. So I am going to depend on calcium channel blocker, L-type calcium channel blocker, that is a cardiospecific drugs. There are two drugs, Diltiazem and Verapamil, but I'm going to stick with the Diltiazem. This has a unique mechanism, therefore that is very good. Also, you can use it a bolus, IV bolus in the emergency department, so you can trust that drug also. So, of course, that's not the like real first line, but first line we were talking about beta blockers. But okay, what if you need an alternative solution? You can trust with the calcium channel blocker. Okay, we already learned 4 drugs, okay? Now, let's look at that little more detail. Remember, I was talking about ventricle story, these 2 drugs, and atrial story, these 2 drugs, okay? Before we go to the classification mechanism, I wanted to remember some easy things, okay? I was telling you why this is a super drug, amiodarone, even though it is a potassium channel blocker. Remember, in the ventricular or cardiac cell action potential, you remember when the sodium channel rush open, depolarization happening, then plateau phase, the muscle contraction, then your repolarization phase, right, refractory period right here, right, with a potassium efflux. Okay, that's a target of these drugs. Of course, we're going to come back there in details, but keep in mind, amiodarone mainly targeting in this phase. All these potassium channels in the cardiac muscle supposed to be open to rush out all the potassium efflux. The problem here is the patient has arrhythmia, a lot of potassium channel opened and crushing all these out. So we use amiodarone. It's going to block a lot of potassium channels and keeping limited. In addition to that, this is going to block some of the calcium right here and also some of the sodium channels and beta blocking ability we're going to discuss. So all together, this will give a controlled inhibition. That's the reason this is different than other drug. Okay, fair enough. You understood potassium channel blocking is at that phase 3, this stage. But sodium channel blocker is at the phase 0 phase. It's like a voltage gated sodium channel blocking. Very quick effective. Okay, so that means like amiodarone, sodium channel blockers, all those drugs also working in that cardiac muscle, in the ventricle. It can affect on atrium also. We will talk about that. All those cardiomyocytes, right? So generally, if a patient coming with arrhythmia, these cardiac muscles are like making like so much impulses, right? Oh, the normal sinus rhythm supposed to come from SA node, AV node and distribute and disappear. Instead, some of the ventricular or atrial cells are going to stimulate and making new impulses. That's what we are going to block with these drugs. So generally, sodium channels are blocked so that these extra activated sodium channels, super activated sodium channels, going to be blocked. For instance, if a patient has like about 1000 in one cell, 1000 sodium channels are like too much firing activated. We need to control. 900 will be shutting down, 100 will be working, so that the normal rhythm will be retained, okay, or regain. Okay, just remember, understand that point. Why I wanted you to think that is, if you are confused, okay, now onwards it is simple. This is the figure I want you to remember for sodium channel blockers and potassium channel blockers. This is the target. If you forget everything, this is the two things to remember. Sodium influx will be blocked. If an arrhythmic heart, if have so many sodium channels are keeping it open and flushing, like a depolarization is so quick and activated, you can regulate it by this drugs, sodium channel blockers. But potassium channel blockers are affecting in this side of the face of the action potential cardiomyocytes, so that you can, instead of like a too fast repolarization and depolarization, the using potassium channel blockers, the depolarization will be like a slow. That means a lot of potassium channels are controlled blocking. Therefore, you can make sure the heart get enough time, and instead of too fast contraction, it will be regulated. Okay, that's a basic things. But why are you comparing that with the next two classes, beta blockers and calcium channel blockers? Okay, stay with me, easy. I want you to keep in the class. I didn't mention because it is sometimes it will be confusing you, but I want you to remember this point. Why beta blocker is a first line for atrial arrhythmias? Look at that. In the pacemaker action potential, you remember this type of graph. I want you to remember only 2 points here. Pacemaker action potential is depending on the calcium channels, L-type calcium channels in the SA node, AV node, right? Conduction. And there is one more point. There is an HCN channels there. If you are too much confused, don't remember that. But it would be very helpful to distinguish beta blockers and calcium channel blockers in arrhythmia. How? Beta blockers, if you are asking me, this has an indirect effect on this curve, right? How? Okay, if anybody asks you how beta blockers work in arrhythmia, easy answers. I have beta 1 adrenergic receptors for the for stimulation of sympathetic nervous system, aggregated in my SA node and AV node and throughout my cardiomyocyte, atrial and ventricle, but ventricle it is so high. But we are going to stick with the SA node, AV node story. For instance, why do I need that beta adrenergic receptor sympathetic nervous activation, right? If I end up in seeing a snake or like a tiger chasing me, I have to run away. So to run away, I need a lot of energy in my muscle, skeletal muscle to run, right? So that my heart has to pump really, really fast and give a lot of blood supply. What if arrhythmic condition? If the heart is too much, like beating is so fast and quivering, or the heart is working too fast, what do? You target that receptors. Those receptors are activated here in this heart. So if you use beta 1 receptor blockers, specifically drugs like Metoprolol, Esmolol, etc., these drugs will go and bind on those receptors and slowing down the heart. How? That's a point. Indirectly, it's going to give signal to this HCN channels and the L-typed calcium channel in the SA node and AV node, so that if you have like a 170 heartbeat, it's going to come down to 100. Like, you got the point. So that's what here we do. Indirectly, directly blocking the beta 1 receptors. This is going to indirectly shutting down the HCN and calcium channel so that you can control the heartbeat. Fair enough. What if the next one? Calcium channel blockers. What do you have to remember is there is nothing to do with beta receptors or sympathetic nervous system story here. Here calcium channel blockers are going to directly inhibiting this calcium channels. This is the place. So that is the reason. This is not the, okay, you can say that, but still, if you are going for the first line or like a rhythm control drug, everybody talk about beta blockers. You understood the reason. But calcium channel blockers also are effective because there are specific unique L-type calcium channels, L-type calcium channels are present in AV node, SA node and throughout your heart. But if you are using these drugs, specifically Diltiazem, if you are using, it has specific calcium channels in the SA node and AV node will be controlled. This is the reason these two class of drugs, you remember this picture or you remember this picture with the target one. That is why it will be very effective for atrial arrhythmias and controls. Okay, you study that unique differences later, but generally this is what you're supposed to remember. Okay, very fair. Let's move on. What about if I have to remember, let me remove this pictures. Okay, so Flecainide and Propafenone, two drugs in sodium channel blockers. We were talking about IV drugs, right? Up to here we were talking of major IV drugs. Metoprolol, succinate, of course, we even learned earlier. This is oral drugs available, but that's a commonly used one. But we were talking about IV case, like acute, like really patient is really in a risk. Okay, we saved the patient. Ventricular arrhythmias, atrial arrhythmias, very good, fair enough. Let's look at the maintenance therapy. Flecainide and Propafenone, of course I'll teach you how to divide all those, but just keep in mind, understand that these two drugs are pill in the pocket, PIP, that's how I remember. So these are sodium channel blockers, very strong effect. That's why you can trust these drugs. If you don't need to keep that, patient doesn't have to take the pill every day, but they will carry around in their pocket whenever they get that specific, we're going to discuss specific arrhythmias, they take that pill and that will work. Okay, that's how I remember. Another pill, Dofetilide, potassium channel blocker. Of course, Sotalol has IV and oral drugs available. These are also very effective potassium channel blockers. You can use it for maintaining heart rhythms. Specifically, we were talking about ventricular arrhythmias. And Dofetilide is like a double-edged sword. That means there is a good edge of this drug and a bad edge. I'm going to discuss that, okay, soon. Maybe I should mention that now because Dofetilide, bad problem is it can lead to, out of all these drugs, this is the big drug, can lead to Torsades adverse effect. Remember earlier we were talking about magnesium sulfate. We can use it as a first line if anybody has Torsade. But regularly for arrhythmia, when the patient takes this, and if they end up in having given Dofetilide, we will talk about unique potassium channel blocker, very good drug, but some patients it can lead to that adverse effect. We will talk about it. Okay, so let's finish with the Quinidine and Procainamide. Okay, Quinidine and Procainamide, what you have to remember while I am keeping this picture, look at, this is a sodium channel blocker right here. But Quinidine and Procainamide, this class 1A has an additional mechanism. In addition to sodium, it can also block this potassium channel also, little bit. Therefore, it can cause QT prolongation, all those. Just remember. So that means out of all those, strictly we discussed the functions, but the extra we were discussing as Amiodarone we discussed earlier. It has to be strictly potassium, but it has an additional mechanism. And sodium channel blocker class 1, it's supposed to be like a sodium channel blocker, but it has an additional potassium channel blocking. And Sotalol, remember, if anybody talk about LOL drugs are beta blockers, right? But why I put that in potassium channel blocking, that's all you usually remember. But Sotalol has an additional, in addition to strong potassium channel blocking, it has also a beta blocking effect. Okay, even Sotalol can be given to pediatric patients. So those are the unique things I remember. Okay, Verapamil. So let's look at one by one class. Okay, with some more mnemonics. Okay, so let's look at the class 1 antiarrhythmic agents, sodium channel blockers. You may see in this picture, but I don't want you to worry much. I am going to teach you what it is. Just look at this one. So this is what I want you to remember, right? Sodium channel blocker, how do you distinguish 3 subclasses? Of course, these all are sodium channel blocking happening in the phase 0. That's what class 1 drugs name is class 1. So instead of, I supposed to have, because the patient has arrhythmia, so instead of having like a fast, like a really, what is it called, like a narrow QRS, anyway, so the arrhythmic signals, so you are going to stop some of the fast opening or fast acting sodium channels. You don't want all the thousands of sodium channels open in a cell in a specific time, but you need to control because the heart is really going crazy. So you use the sodium channel blockers. In that time, class 1, class 2, class 3 has different effect. Why is it important? Oh, just remember 3 things, you are good to go. So let's look at it. I want you to understand something. When the sodium channel is closed stage or open stage, think about a door in your house, okay? When the sodium channel is open, the door is open, the first class work really well. It can bind on it, or it can also bind on the closed door also. Either way, they're going to stuck there and they're telling the cell, no, we are not opening the sodium channel. Anyway, you have to control the arrhythmia. Of course, you remember, along with that, we are going to inhibit some of the potassium channels. That's why, if you look at the blue graph, you can see that. I'm not going to open all the sodium channels at one time. No, even it is start opening, you give the drug. As soon as it reaches the body, it's going to into the heart. It's going to slow down the sodium channel opening. Very good. And blocks and coming. But instead of shutting down too fast, that is the like a very short, very small action potential. You can see that there is a stretch in the QT prolongation, reason of the potassium channel additional point. Okay, that's why if you see a picture like that, you don't have to worry about. See that class 1A, Quinidine and Procainamide. Let me give you another mnemonic to remember that. Okay, this is how I remember, if I have to remember all the 3 class 1A drugs. Of course, when you go to board, you may need it in the class or in the first stage. When you learn, you remember Quinidine. That's enough. So this is the mnemonic, right? So there are 3 drugs in class 1A. All are sodium channel blockers. Quinidine, Procainamide and Dysopyramide. So how I remember is Queen, proclaims a dynasty or Dysopra, opera, or whichever way you remember. Quinidine, Procainamide proclaims A is class 1A. That's a one mnemonic if you like. Okay, we will go to the next mnemonic. But anyway, Quinidine story. Okay, in Quinidine, remember it is good for short QT syndrome. And reason, see, if it is a short QT, because the potassium is also regulated, this will be very effective. Another point I would like to mention, remember quinine, we used to use it for what? For the IV quinidine, you can use it for malaria, right? Severe malaria, right? So that is a very toxic drug. That is the reason for arrhythmia nowadays, because you have a lot of alternative there. Nowadays, not the go-to drug is IV drug is not the one given. Oral will work. Okay. So therefore, quinidine is a very strong cinchona-derived drug. So therefore, quinidine study, I am going to mention something about Procainamide. Anyway, so keep in mind, let's look at some points about quinidine. Major point is sodium channel blocking, right? It can prolong inactivation is there. What is the reason? Okay, it can bind on, if anybody asks you to distinguish the three types of sodium channels, you think about this closed and open channels, these drugs can bind. An additional potassium channel blocker, that's all you need to study. Then you just add some more synchronism, that is an adverse effect. Then of course it can cause QT prolongation, not much, don't remember too much, then you will forget everything. If somebody asks you to distinguish these two drugs, Procainamide, specifically if you have indication acute AFib with a Wolff-Parkinson syndrome, you can give this drug. And also Procainamide is having a unique adverse effect similar to generally if you talk about drug-induced lupus. There are two drugs in the cardiac pharmacology. One is hydralazine, and the second one is Procainamide. Procainamide has an ability to bind on histones in your DNA, and so that it will act like a Hampton. So your immune system going to be like a freak, they're going to be upset and attack. That's why lupus-like syndrome going to be showing with this drug. That's the reason. These are with a very narrow therapeutic index drug. Okay. The next one, let's move on. Second one is weak active inactivation Lidocaine drug. Lidocaine, what is the big thing I want you to remember? See, why? How is it different from others? This drug can bind during the inactivated stage of the sodium channel. How do you remember this? Easy. It's like a door closed, door open, and door is about to close, but it is cracked open. That means door is not closing well. Some of the sodium channels are not closing well. What is the reason? The patient get myocardial infarction, right? Got myocardial infarction. Some of the myocardial tissues, sodium channel specific. If you are wondering, there are specific sodium channel at this point that will be still keep opening in this stage 2, phase 2 of the cardiac action potential. But if it is too much, don't remember all those details. But just remember, these drugs can uniquely go and bind on the inactivated stage of the sodium channel. Therefore, if you are listing all the other drugs, this is the best drug for this. Can easily work on the ischemic tissue of the heart. So if the heart is ischemic after the myocardial infarction, lidocaine and this class B drugs can get into these tissues very easily because of the high potassium level, and even though this lidocaine, remember this is a local anesthetic, right? In the acidity, it is not like infection. During the infection time, the local anesthetic dose has to be increased or it won't work well. But in the cardiac muscle, entirely different reason, the outside potassium level will be, efflux will be too high in these cells, and also because of the membrane polarity difference. Remember, Q cancer, lidocaine love myocardial tissue. That's all, sorry, the death or ischemic myocardium. That's all you need to remember. So what it will do is going to work really well. And where is it working? Why is it unique than other drugs, other drugs? Reason, this is loving to bind on specifically, that is mainly binding on inactivated or crack opened door, only partially, like it is about to close, but that's where, but it's not closing because myocardium tissue is completely damaged. That's why, if you are asking all the details. Anyway, so the next one, let's move on. I think lidocaine, what else you have to remember? Nothing much. You need to remember the mechanism specifically. That is important. Why it is good for ischemic tissue. That's a super important points. And the third one is pill in the pocket. Same thing. Mechanism. Remember, oral drug. Why are you using this specifically? If you are asking, paroxysmal atrial fibrillation. That's a good drug. And Propafenone and Flecainide. I remember with a mnemonic for all these class 5 drugs, right? Because for board 5 drugs are important, for class 3 drugs are important. I remember pill in the pocket. This is how the story I remember, like you can remember with the Quinidine and procrastination story, or Queen proclaimed, or the Dysopyramide, or a Dynasty, and because Queen's princess or daughter Lydia in the class B, Lydia is proposed by a Fle-C in class C, or whichever way you remember that. Okay, it's an mnemonic if you like. Okay, let's move on the class 2 beta blockers. Let's move on very fast. It's already 30 minutes. Okay, beta blockers, go to drug, in unique drug, that's what I'm going to explain. Okay, I was talking about commonly used like a Metoprolol, very good drug, and even the non-specific drug Procainamide can be useful also. But Esmolol IV, you can use it for like a IV, right? I was talking about very fast acting drug, right? So this one target you already know. SA node, AV node specific receptors are there, beta 1 receptors we already discussed. So this, why do you use these drugs for in emergency medicine? Because it works, a fast acting drug. It's not seconds but minutes. It take about 60 seconds to work, 1 to 2 minutes. Remember that. Also, what is a super important other point? This drug can metabolized by the erythrocyte esterase enzyme. That means it's too many erythrocytes in your blood, so it will be metabolized very fast. That means it go to the heart, do the duty, and get out, removed. So job done very well. It is removed within about half-life, about 9 minutes. Okay, fair enough. If a patient is has multiple diseases, you can depend on other drugs, no interaction, nothing, good to go. That's a good thing about Esmolol if you are asking me. Another point I would like to mention, if you are seeing this drug with a Sotalol, Sotalol is not a specific beta 1 receptor blocker. No. Beta 1 receptor blocker, Esmolol and Metoprolol is the best, unique, like a very good drugs, beta 1 receptor specific. Propranolol is non-specific beta blocker, but Sotalol is actually a potassium channel blocker with beta blocking ability. That is why you may, I don't want you to confuse with that drug. Okay, just remember this take at least hours to work, not a fast acting drug. Okay, so you cannot trust for like a life threatening working in couple of seconds or minutes. No. So just understand there is a drug like that. Okay, let's talk about potassium channel blocker. That's a big guys are in that class, right? So what do you remember in this one? And let's start with the Sotalol first. That's why I put it there. 3 drugs. How I remember with a mnemonic, AMI or Amio or AMI, whichever way. AMI is a daffodil seller. So Daffodilide and Sotalol. That's how I remember, whichever way you can remember. So let's talk about that. Amiodarone drug, Sotalol. Let's look at the Sotalol first. I was talking about this drug is like a oral and IV are available, and you can even use it for even pediatric patients. We can use it, right? I was talking about. Let me see if anything else like life-threatening arrhythmias, ventricular arrhythmias, maintenance therapy, oral drug you can use it. What is the mechanism? Easy. Look at it. It can block the potassium channels so that the potassium efflux will be controlled, so that instead of like really fast arrhythmias, it can control and make the prolonged repolarization, so that of course these drugs can cause QT prolongation, but nothing much to worry about those points, because understand what is the real mechanism, why it is causing QT prolongation. See that? It is specifically blocking that area. In addition, Sotalol can block general beta receptors also. Anyway, this is the major one. That's why it is in this class. Very good, Sotalol. Then maintenance drug. Okay, so let's talk about Dofetilide. That's also, there is no IV in Dofetilide, only oral drugs available. This is how I remember. Okay, so oral drug, what is happening here? This is also specifically potassium channel blocker, exactly same mechanism. But this is like a very unique, while it blocks this potassium, sometimes it blocks so many potassium channels, and the next action potential, next sodium, depolarization can start too early, and it end up instead of coming down, it's go like really twisting and turning, making a torsade. Torsade is the point, right? So this is one of the adverse effect of Dofetilide. Hope you understood with this picture. It's supposed to be going like this in the red line. Instead, the condition can become Dofetilide can lead to this arrhythmias. Does that make sense? So Amiodarone, of course, I was talking about controlled. We will talk about that in the next section. But this Dofetilide adverse effect is torsade. Let's move on. Mechanism of action, you already know that oral drug with a strict potassium channel blocking. Fair enough. The next drug is Amiodarone. Amiodarone, in addition to potassium channel blocking, why in this picture Amiodarone showing very controlled and like a really very good action potential control reason, slowing down the action potential like with a long refractory period and all reason. In addition to potassium channel blocking, this also blocks some of the sodium channels and some of the calcium channels. So calcium influx and sodium influx will be controlled, so that there is no early depolarization. Say nothing. It is little bit controlled. But the problem is this is very strong action, so therefore a lot of adverse effect when they this because of its chemical nature. Okay, understand. Okay, let's move on. Like I said, like prolonged duration of action potential. That's why this drug can control almost all type of arrhythmias, right? If you are anybody asking you to distinguish those drugs. Okay, so let's talk about adverse effect. That's a big guy. For the board like to ask those questions in addition to these mechanisms, right? Reason. I want you to remember 3 things. You should never forget this. Amiodarone has an affinity to lacrimal glands. This is has deposit in the lacrimal gland, thyroid gland, and also in your pneumocyte 2 cells. Remember, pneumocyte 2 cells are the one producing surfactant, right? Remember that? So in your pulmonary, like that is your lungs, pneumocyte 2 cells has to produce a lot of surfactants. So type 2 pneumocyte cells, right? So these cells going to be specifically, right? These cells over accumulation of amiodarone will result lower phospholipid metabolism. That's a real reason if you're asking me. So the pneumocyte 2 cells are going to be dead, poor cells, right? This amiodarone going to be accumulating, and instead of surfactant secretion, is going to stuck there in our pneumocyte cells, and is going to be died, and fibroid, that means especially high dose long-term therapy, fibrocytes cells or fibroblast cells are going to activate and replace those cells. Poor thing. This can lead to pulmonary fibrosis. That is a severe and long-term therapy can lead to in some patients. Like that is a severe but rare adverse effect, right? Severe, life-threatening, you must remember that adverse effect. if anybody asking you what are the common adverse effects, that's how this is the 2 adverse effect. Out of that, if we ask like a second, most common will be eye problem. That's the first signal. So that time we should stop the drug and go for another drug. Okay, let me talk about the story. Amiodarone the structure has iodine. Each amiodarone molecule has 2 iodine. Okay, so daily, if you have the patient taking about 200 milligram amiodarone, the daily iodine is like about 0.2, something like very little you need it, but it really is about 40 times iodine in your blood. So that, of course, is going to go and bind all your thyroid cells, and it can cause some patients hypothyroidism, some patients hyperthyroidism. But just studies thyroid dysfunction. That's a big guy for amiodarone. You understood the attraction because the structure with iodine. Fair enough. The second one, this drug also has an affinity towards the lacrimal gland, so that from the tears you are going to secrete a lot of amiodarone into your eyes. So what I remember, like amio, that's a drug short form. Amiodarone my eyes and thyroid. That's how this picture can be useful. But remember, this can cause micro deposit in your eyes. So that means corneal microdeposit, because it will adhere with that attraction to the lipid molecules, right? Those point similar to our pulmonary pneumocyte 2 cell mechanism. It's entirely little bit different because of the accumulation. The organ is different, lacrimal gland, but it is secreted into your cornea. Here, the mechanism is actually affecting the corneal tissues. So the eye will be having problems. So 2 adverse effect. One organ is your thyroid gland. Second one, just forget about lacrimal, because real mechanism is through the lacrimal gland. That's why I put the picture. But your adverse effect, really I want you to remember the corneal micro deposits, right? Amiodarone induced corneal problems because of the amiodarone lipid complex formation. Okay, that's it. Let's move on, and we are almost done. Okay, so calcium channel blocker, you already understood the mechanism. Diltiazem, I forgot to refer that point. Diltiazem differed from Verapamil because Diltiazem has an ability, it can bind in the L-type calcium channels even in the open stage inside, and also it can do that, the point is like it can change that structure, shape of the channel, so that this drug can bind both in the cardiac muscle and also in the blood vessels, right? That has a dual function. But remember, if anybody is asking why this is a stronger drug, because its binding is inside the calcium channel also. That's a reason. It share that binding site, okay, compared to Verapamil. Then you know that what is the difference we were talking about. Here there is nothing to do with the beta blocking or anything, but calcium channel, of course, you have throughout your muscle, heart muscle. But if you are talking about focusing on the action potential in the SA and an AV node, calcium mediated one. So here depolarization is calcium dependent. So these drugs can go and bind the specific directly bind and block the L-type calcium channels. That's why this will be effective. Instead of the SA node is firing like hundreds of like a 200, 250, like really fast beating. See that? By slowing down this, it's going to make it like instead of 2 beats, you have only 1 pacemaker signal going. Okay, similarly. Verapamil, these drugs can cause other, because we have these channels, L-type sodium channels, calcium channels are present in our smooth muscle also, in your intestine, in the colon and all. We have these drugs can bind to this L-type calcium channel, but Verapamil, keep in mind to distinguish these 2 drugs, Verapamil is the drug which can cause like a strong adverse effect. It's called the constipation, because it will block the calcium channel in your intestine. Okay, so last two drugs we were talking about, magnesium sulfate. Let's talk about that. Magnesium sulfate, what I wanted you to remember is, this is the drug which will be given IV. We already mentioned that. Go to drug for torsades, right? It's just an electrolyte if you really think. What is the mechanism? Super easy. Because it is an electrolyte, it's actually physiological antagonist of the calcium channel, L-type calcium channel. Therefore, if a patient has like a really torsade in their heart, this drug, this is like a very easy to work. This going to disperse in the tissues and going to bind and block the the calcium channels, and physiologically it's going to block, so that less contraction of the overall cardiac muscles. In addition to that, it can affect your, if you put a picture, it can also affect your sodium potassium ATPase mechanism, right? So because it can stimulate, so that the potassium efflux will be slowing down, and it's going to initiate a lot of potassium efflux also. That means it will activate some of the potassium channels, so that the potassium efflux will be happening and regulated. Therefore, the big, because there is especially hypokalemia can cause torsades, right? But this condition can be reversed. Of course, hypomagnesemia can cause torsades. But if you are providing a lot of, they are opening a lot of potassium channel also, in addition to that, slowing down calcium. That's why when you look at the picture, you will see the difference. This picture will be showing mechanism involving calcium channel, that is, magnesium sulfate is a physiological calcium antagonist, very good, controlling, slowing down, not too much calcium influx anymore, because cell is overloaded with calcium. No, we don't need too much arrhythmia there. No, it's going to control, slowing down. In addition to that, it's going to open some of the potassium channels. Therefore, it's going to give that double mechanism it has. If you forget about that, at least remember one mechanism. If anybody, don't forget that, because hypokalemia can cause torsade. If somebody asking why magnesium sulfate is effective, this is the mechanism. These two, along with this two mechanism, calcium plus that active calcium is slowing down, right? You need to shut down too many calcium. No, we don't need it. But you need to activate it. There is very low calcium, potassium channel open. So you are going to open a lot of potassium channel, so that enough potassium channels working, so that you are going to get a good QT prolongation, controlled QT prolongation, and the torsade will be breaking down and getting a normal action potential. Fair enough, we are almost done. But keep in mind, for any go-to board, remember, if a patient has myasthenia gravis, magnesium sulfate is contraindicated. Of course, I'm going to teach you I think in some other lectures in the later in days, I'm going to teach you that part, but don't worry about that now. Adenosine, last point. What is the uniqueness of adenosine? This drug can cause you can indicate it specifically. We were talking about AV node dependent re-entry tachycardia. This is a very effective drug. Okay, so keep in mind, this is a first line for to stop and restart your heart briefly. Okay, and acute termination. Narrow complex supraventricular tachycardia is the one mainly we are going to use this drug. That's the reason if a patient has a delta wave in the, remember that in your Wolff-Parkinson-White syndrome condition. So let's look at with a picture, okay? So keep in mind, about 10% of patients with a WPW syndrome, there is an accessory pathway, right? In that 10% of patient, the major SA node conduction, it's supposed to go through AV node, but no. It is going through the accessory pathway and coming back through the AV node. If you use adenosine in this patient, adenosine is a drug which can block the AV node for a couple of minutes or seconds, that's a word. I will tell you with another picture. Don't worry about it. Understand. Okay, maybe we will look at it. AV node has a lot of adenosine receptors, A1 receptor. Memorize that. A1 receptor is present in that specific AV node, okay? This is entirely different than beta blocker stories or calcium channel blocker story. This is a unique mechanism. In AV node, you have naturally present a lot of adenosine. This is the story about if you drink a lot of coffee, right? Like a heartbeat goes up, all those stories. Anyway, adenosine, if you give a specific concentration in short time, this can completely shut down the AV node functions. AV node will be completely stopping this by different signals. The problem here is if there is a accessory pathway is very strong, if you shut down this electric current, the accessory pathway going to generate and stimulate all your ventricle because a lot of strong conduction, and it's going to, because it is not escaping through this AV node, the heart can cause a lot of ventricular secondary arrhythmias. That is a no-no. That can be lethal, deadly. That is the reason we can use only if this is an orthodromic. So that is the previous was called the antidromic. The orthodromic condition, like orthodox, then regular pathway. Okay, normally the heart is beating, AV node, SA node conducting to AV node and going through the normal pathway. But the accessory pathway is coming back into this. But if you block, let's talk about that. If you block the strong current for a couple of seconds, okay, it's completely disappear here. Even if it is little bitty signals stuck here in the ventricle, nothing to worry. You are not going to get like a real ventricular arrhythmia, secondary proarrhythmia is not going to be there. That is the reason 90% of patients, this is a good drug for stop and restart the heart. How do you do it? With IV push. Okay, pay attention. Why we can rely on this drug? Okay, if you are going to stop your heart for a long time, the patient get AV block and you will lose the patient. The heart will not be able to restart and the patient can die. That is the reason. Super important IV emergency department drug. IV push with after that you're going to give the saline. You will learn that in clinical. But just remember, what is the significance? Adenosine, body know that if any time too much adenosine in the body, nothing to worry. This is the adenine, guanine, thymine. That is, it is essential for your body. So body already has a preparation, right? Because body cells are like rich in adenosine, right? Because adenine plus ribose sugar, adenosine. This is also a part of ATP, ADP, AMP, remember? So adenosine is supposed to be throughout your body. So in case if any time it is overloaded in your blood, there is a separate mechanism to block or stop down. That is the mechanism physicians or doctors or scientists use to treat arrhythmias in specific conditions. You shut down the heart for a couple of seconds. Oh, you don't have to worry about anything because look at that. Your millions of RBCs and endothelial cells, they have specific mechanisms to break down all those adenosine molecules. They have specific, metabolism by adenosine deaminase. Remember, adenosine deaminase is present in RBCs and endothelial cells. So you can trust that. This is going to, like, whenever they see the excess adenosine, they're going to deaminase and like deactivate it. That will be within second. You can trust that because all our body cells are going to be like chopping down very quick. So you make sure as soon as you give this IV push, it reaching up to your heart, right? Easy, you can remember, right? The blood is exposed to the AV node. So as soon as it get like push, within 1, 2, 3 that seconds you get it, the patient feel like really sometimes like a pain and all those because you are stopping the heart. How? You can look at right here with the picture. If the patient comes with arrhythmia 170 beats per minute, you give the IV push with the adenosine specific concentration. Do look at that. Next few seconds, the heart just stopped. Look at that, right? Very low beats, and any re-entry, all the pathways stop for a couple of seconds, and the heart regain its mechanism because AV node is sending the signals, right? The block is right here. So it's going to ring, and look at that, 100 beats are stopped, gone within seconds, and changed into 78 beats per minute. This is a unique drug and works really well. That is why board like to ask. Okay, so we are almost done. Yeah, we are done. And this is a review, and make sure for board can review my other lectures. I will be adding more soon, and please subscribe, it would be helpful. And thank you. Hope it helps for your board review, and all the best.